Good morning, everyone. So, in this session, I will be discussing about safe anesthesia practices for resuming elective surgeries during COVID area, and I will be covering physiological changes due to COVID, assessment of respiratory and cardiac reserve, setting up of COVID OT, pre-anesthetic considerations and preoperative considerations, intraoperative considerations, and post-operative considerations. So, coming starting with the respiratory changes. So lungs are the most affected organ in COVID-19. The virus damages the walls and linings of alveoli and capillaries, and this damage leads to accumulation of the proteinaceous material along the alveolus wall and resulting in thickness in the lining, and this wall thickness hinders with the transfer of oxygen to the RBCs, and more the thicker wall gets, the more difficult it gets for gas exchange, ultimately leading to consolidation, acute respiratory distress syndrome, which leads to fibrosis, leading to restrictive patterns, resulting in deranged pulmonary function tests. So there is a study in which a follow-up CT and pulmonary function tests were done at 3 months after discharge, and it was found that even after 3 months of discharge, significant residual abnormalities in pulmonary function tests were observed in around 25% cases, and most of these abnormalities were related to the gas diffusion. And on the radiological aspects, around 75% patients had abnormal radiological findings in the CT even after 3 months. So second most common organ which is affected is heart and vascular system. So in cardiac manifestations, there may be tachyarrhythmias, myocarditis, acute coronary syndrome, heart failures, secondary to pneumonia, as well as independent heart failures have also been reported, cardiogenic shocks, and patients who has hypertension and diabetes as a comorbidity has most adverse cardiovascular outcomes. Other systems which can be involved are renal systems, and ongoing inflammatory process is also there, and there are a lot of psychological and social issues. So coming to the assessment of cardiovascular system before surgery, patients respiratory functions can be assessed by pulmonary function test. As I have already discussed, 25% patients have abnormalities in the pulmonary function test even after 3 months. So this is a very good test if we are planning for surgery in a COVID recovered patients. And then if X-ray chest shows persistent changes in the form of fibrosis, that is indicative of severe dysfunction. And then for cardiac, ECG and echo can be done. And for overall assessment of cardio respiratory reserve, a 6-minute walk test is a very good test. And this is a simple and reliable tool which was initially used to assess cardiorespiratory effort tolerance in chronic lung and chronic heart failure patients, but nowadays it's being used in COVID patients also. And this test provides a global assessment of cardiopulmonary reserve. This is a simple test in which we have to measure saturation by pulse oximeter before starting. Then we can ask the patient to walk at his own pace for 6 minutes, and at the end of activity we have to measure the SpO2. If SpO2 is less than 94% or there is an absolute drop of SpO2 by 3% from the baseline, that is indicative of poor cardiorespiratory reserve. So this is a simple test which can be used. Then coming to pre-anesthetic checkup, we can do tele-PAC by the help of telephonic call or video call, and history related to COVID symptoms and medical history can be elicited. And if telemedicine facility is available, physical examination can be done in the form of auscultation, blood pressure measurement, heart rate, etc. And airway examination can be done through video call also. And if there is any requirement of consultation, that can be arranged, and investigations can be seen through HIS or as shared by the patient through WhatsApp or other similar apps. Then just after admission, PAC is done, and if it tele PAC has already been done, that can be confirmed, findings can be confirmed. If it's not done, routine PAC can be done with extra precautions depending on the COVID status of the patient. And along with the conventional PAC which we are doing, we have to check specifically for presence of fever. We should check for saturation and respiratory rate also, and auscultation should be avoided uh, if possible, and if it has to be done, preferably it should be done through electronic stethoscope. And in investigations along with the routine blood and radiological, we should check for the COVID test also. Coming to the setting up of COVID OT, dedicated operation theater should be used for all COVID confirmed or suspected cases, and ideally a negative pressure OT should be used. And the operation theater should be clearly labeled as COVID-19 OT, and ideally there should be two COVID OTs, one for obstetrical procedures and second for other surgical procedures, and it should be located in the dedicated COVID center and preferably near the COVID ICU or HDU. Coming to the air conditioning of OT, majority of the operation theaters in India are not planned as negative pressurized OTs. So the simplest way to do this is to convert existing OT into COVID OT is to convert it into 100% non-recirculatory system, that is 100% fresh air should be pushed in, and this can be achieved by blocking off the return airway vents. And second best possible option can be standalone room air conditioners like split ACs can be used, and room temperature should be kept between 24 degrees to 30 degrees. Scavenging is also not available in most of our OTs. So what can be done? Carbureted tubing can be applied to the scavenging port of the anesthesia machine, and this can be dipped in a bucket with 1% hypochlorite solution, which have been suggested. And the person who is doing this should wear proper PPE while handling this. There are guidelines regarding number of personnel inside OT so that exposure can be decreased. So minimum 7 to 8 persons are required normally. There should be proper mock drills regarding donning doffing of PPE, as well as for wheeling in and wheeling out of patient into the COVID OT to accustom and know the practical problems. Coming to the planning for elective surgeries, the patients who are coming for elective surgeries might be COVID positive, COVID ambiguous or patient under investigation, COVID negative, and the fourth group might be COVID recovered patients. So for COVID positive or COVID ambiguous, treat them like COVID positive, and only emergency surgeries in dedicated OTs should be done, and no elective surgery should be done. In COVID negative, emergency surgeries and oncological surgeries can be done, but regarding elective surgeries, the decision should be made on case to case basis. And in COVID recovered patient, there is paucity of literature, so it has decision should be made on case to case basis. Maybe it can be done by making a committee which decides which patient has to be taken for the surgery. Then a choice of anesthesia technique. The basic principle is good communication between anesthesia and surgical team, and most experienced persons should perform the procedure. Use definitive technique, avoid newer and less familiar techniques. If duration or complexity of surgery means a high probability of conversion to general anesthesia, it is better to start with general anesthesia rather than converting it in between the procedure. So careful consideration should be given, and minimum persons should be available in OT. Regional anesthesia is a good choice if surgery is possible under regional anesthesia, as it can avoid the need for GA, intubation, and risk of aerosolization. However, COVID patients who are on anticoagulant, the decision to use neuroaxial anesthesia and timing should be decided whether patient is on anticoagulant or not. So during entire procedure, when surgery is being done under regional, patient should wear a surgical mask or N95 mask at all the time throughout the procedure, and if supplemental oxygen is required, lowest possible flows of oxygen should be given, and preferably oxygen mask should be placed over the surgical mask. In general anesthesia, sedative premedication should be avoided,
Ashish,
and
you have 2 more minutes, please.
okay, in induction, rapid sequence induction should be done, and these patients are more prone for hypoxemia and hypotension, so utmost care should be taken. And the drugs like propofol, which causes more hypotension in these patients, should be avoided or should be used with ketamine. So minimum personnel should be inside the OT, maybe 2 or 3 anesthesiologists, and one person should be outside the OT to help in case of crisis. A senior most person should intubate, and pre-oxygenation should be done with the two-hand technique for 3 to 5 minutes, and positive pressure ventilation should be avoided, mask ventilation should be avoided, and if it has to be done, it should be small tidal volume, and video laryngoscopes are preferred for intubation, and intubation should be safe for the patient, and staff should be accurate, avoiding unreliable, unfamiliar, or repeated techniques, and should be swift, should be done timely without rush or delay. And awake fiber optic intubation should be avoided in due to danger of aerosolization. Avoid open suctioning, avoid high flow devices, and proper decontamination and disinfection of all equipment should be done. During maintenance phase, minimize tube and circuit disconnections, and closed suction system should be used, and lung protective mechanical ventilation should be used. Supraglottic devices should be used only for airway rescue, and routine use should be discouraged. And during emergence, it should be smooth, and extubation should be done in OR only, and patient should be monitored in the operation theater and should be directly shifted to isolation or ICU. In obstetric, choice of anesthesia technique should be dictated by urgency of the cesarean rather than the sero status of patient, and regional should be considered as the first line. Single shot spinal with pencil point is preferable. Overzealous fluid administration should be avoided, and exaggerated hypotension can be there. So for treatment of hypotension, rather than using excessive fluid, we should rely on the vasopressors, and carbopress should be avoided due to risk of bronchospasm. And in
Ashish, I think
endoscopy,
you have
ideally
to
should be
summarize and conclude.
performed in negative pressure procedure, and for upper GI, general anesthesia based rapid sequence induction with intubation rather than sedation should be preferred. Uh, Frequent hand hygiene and proper donning and doffing of PPE is essential to prevent transmission of COVID-19 in healthcare workers. Aerosol generating procedure increases the risk of transmission of COVID-19 to healthcare workers. Discuss the procedure and anesthesia technique with the surgeon. Most experienced persons should perform the procedure. Use definitive techniques. Minimize person and equipments. Use disposable devices if possible. Patients should wear a surgical mask during transport. Avoid circuit disconnections, and if needed, leave filter connected to endotracheal tube. Anesthesia machine and other equipment should be protected from viral contamination by filters and clear drapes, and patients should be selected judiciously for elective surgeries. Thank you so much.